Hi guys, good afternoon. Am I visible and audible to you? So give me a quick confirmation in the live chat if you can see me and hear me well. My name is Zainab Vora and I've done my MBBS and MD in radiology from AIMS New Delhi, and I teach radiology on the Unacademy and PrepLadder platform. So today what we are going to be doing is discussing Radiology 101. So as the name suggests, we are going to start with the very basic things and the most important things that are usually a part of your exam. So if you just look at the content of the PDF that I've already posted over the class, you'll realize that most of these have been previous year questions. So all of these classes that we've planned in this series is gonna be a must watch for all of you who are exam going, be it FMG, INICT or NEET PG. So this is the core stuff that everybody needs to do. So before we begin and I tell you about the plan, this is a plus subscription on Unacademy, wherein you get access to everything on the platform, which are the previous past courses as well as the future courses which have been planned. And if you combine it with Iconic subscription, you can also get PrepLadder along with it. So these are the various offers. So the prices have been slashed right now, so now is the best time if any of you is looking to buy it. Now is the best time to do that. All right, and these offers are also there, wherein for 2 years you get 4 months free and for 1 year you get 2 months subscription free. All right, so make the best use of all of these, and these are the various batch courses which are ongoing at the moment, basically starting from 22nd. So you have the INICT batch. So those of you who are targeting, the date is now out. So those of you who are targeting, and I hope a lot of you are, you can make use of this batch course. This is the examinations and procedure batch. Again, something very important for INICT, like I keep telling you guys. This is for the next 2022 aspirants, and again an batch on next, which is an integrated system wise subjects. All right, so these are the various batch courses. In case you're looking to subscribe for an additional 10% off, you can use my code, which is ZURA live. All right, so hello to all of you guys. So this is the plan for the next 10-11 days of this month, wherein we want to do the core topics, like I told you, which are must do for all the exams. All right, so today we want to talk about the investigation, something that you guys are very scared of for some reason when such questions come, and you are realizing that these are questions which are more and more getting asked these days. So we'll try and make a list. We'll try and compile the most important ones that you need to remember, but more importantly we'll try and understand the concept rather than just memorizing ki kiska kya initial investigation hai, what needs to be investigation of choice. We'll try and understand the concept of why, what is the answer, so that is the plan. Yes, this is for FMG also, very important for FMG students as well, because you get a lot of radiology questions. If you see in the past papers in the recent times, 2 years, many radiology questions. All right, so all of these classes are the must know basic classes for everybody. All right, so on that note, let's begin. So today is all thumb rules and all investigations. So we're starting off with musculoskeletal system. All right, so we start off with MSK. Just give me a quick nod if all is good and I can begin. There's no audio visual lag, and we are good to go on our first day on YouTube. So this is MSK. MSK may always remember three things. All right, so three main investigations will come into play. You have X-ray, which is the core foundation, which is the first thing. The second would be CT and MRI. These are the three things that will revolve around, and I'll tell you how everything is linked and how to choose what investigation. Okay, this PDF is already there. This PDF is already there on Telegram, Sahil, so you can get it from the group. Okay, all right guys, so anytime we talk about any initial investigation, all right, so when they ask you initial investigation in any orthopedic condition, be it fracture, bone tumor, arthritis, three of the most commonly encountered questions, what is our answer gonna be? So always nothing can start in orthopedics without a basic X-ray, and it is something which is indispensable. If you give me that, let me do CT directly, let me do MR directly, I will say no. First I want to see an X-ray. Particularly for bone tumor, the evaluation is incomplete without an X-ray. All right, so this is an indispensable initial investigation that you start off with. All right, so this is about any fracture that you want to look at. Like I'm showing you here a fracture of the spiral groove, which is called what is the name of this fracture? When the spiral groove gets fractured and there's radial nerve injury which is associated with this, This is called the Holstein-Lewis fracture. Yeah, so this is a named fracture. We've done these. This is the Holstein-Lewis fracture. Remember, that's there. About that, again, a question which has figured so many times in your exams. So what we are seeing here is a soap bubble lesion, epiphyseal lesion, distal end of radius. Always think of GCT, epiphyseal lesion and soap bubble, and older patient with skeletal maturity shown by the fused epiphysis. Yeah, so any tumor start off, you will see in your exam questions also that invariably you always get X-ray images, isn't it? Here what am I showing you? Any trauma. So not just fracture, any trauma which is related to any foreign body. Yeah, so if I tell you that this person had an injury with a glass bottle and I want to see if there's any retained piece of glass, again you'll say, ma'am, please start off with an X-ray. Alright, so for a foreign body also we want a X-ray. So the first basic point is initial investigation is X-ray. Now let's talk about this. Anytime they give you a question of foreign body, in fact this question figured in your NEET also, something that we've discussed so many times, right? So anytime they give you a foreign body injury, particularly the scenario that they most frequently encounter is the eye. So anytime you have an ocular injury, foreign body, you always start off with what? You start off with an X-ray, like we just saw. Apart from that, in the case of orbital injury or ocular foreign body, remember, one more initial investigation that is done is ultrasound. Alright, so ophthalmologists a lot of times will keep their probe A mode ultrasound, B mode ultrasound, that can also localize foreign bodies if they are intraocular. Alright, so within the globe it can be picked up on ultrasound as well. So remember, these two are initial. Best investigation, any foreign body, it is always going to be a CT scan. So here I have an image of a CT for you. We know it's a CT because the bones are white. And can you see this very dense foreign body in the orbit? So this is how CT helps us. It's the most sensitive, the best investigation to pick up a foreign body. What is contraindicated is again very important, and that figured in your exam actually, right? So it is MRI. Remember, MRI will do more harm in case it's a metallic foreign body like a shrapnel or anything. It will cause detrimental damage to the patient, and that was the word of your NEET PG exam. So MRI, never do it, because MRI, you know, involves a large magnetic field. Any metallic foreign body will get pulled, and along with the foreign body a patient will get pulled, right? So you're doing more harm than benefit. So never ever do MRI in a suspected case of foreign body. Alright, so this is about foreign body thumb rules. I hope everybody is keeping track. Moving on, so anytime they talk about cortex, cortical pathologies or calcification. So C for cortex, C for calcification. The thumb rule says that you go for CT. CT is going to be the best investigation here, right? So what kind of cortical pathologies? So remember, any fracture, what is the best investigation? It is CT scan, because it is a cortical breach, isn't it? But if I give you which fracture, usually will not show up on CT because it might not have cortical breach always. It might just have bone marrow edema. Then you say it is stress fracture. So except for stress fracture, wherein we'll talk about MRI, everywhere else CT will suffice. CT will be the best. Then if I ask you cortical thickening, I want to see, like a case of osteoid osteoma, which is the best investigation, it is gonna be CT. Yeah, so remember, one bone tumor wherein CT plays the paramount role is osteoid osteoma. In fact, on the same note, remember here that the treatment also can be CT guided RFA for osteoid osteoma. Right? So CT plays a diagnostic as well as therapeutic role as far as osteoid osteoma is concerned. As I said, Shalakha, foreign body best investigation. So best, unless mentioned otherwise, will be synonymous with investigation of choice. So CT. Alright, so that is CT. But always remember, in all of these investigative questions, you have to you know, read what the examiner is trying to ask. Try and read between the lines. What is the examiner particularly, you know, hinting at? Are they asking the next investigation, initial investigation? So, you know, don't just go with a preset notion and just memorize this list or this PDF. You have to understand it, absorb it, and then you know, answer based on what is being asked. That is something which is very important. Okay, right. So next we go on to cartilage, ligament, soft tissue, IV disc. Remember, for all four of these, when we want to see the main investigation that we'll be looking at is MRI. Alright, so as far as MRI is concerned, basically if they give you particular examples, that if I want to see a cartilage cap, can you tell me in which bone tumor evaluation is the cartilage cap very important, that it has a risk of converting into chondrosarcoma, and want to see the thickness of the cartilage cap, wherein MRI becomes very important. I'm talking about osteochondroma, isn't it? So osteochondroma exostosis can turn into chondrosarcoma, and this is where I want to do MRI, because cartilage best MR. If I want to see soft tissue sarcoma, again what is best? MRI. If I want to see spinal cord, right? If I want to see spinal cord, CT is not going to be the best. It's again going to be MRI. So these are the ones in the greens. Green are the examples of, how they can translate the thumb rule into questions. IV disc, if I want to see the disc, so like you can see in this MRI, anytime I want to see disc prolapse, I will do an MR. Can you tell me, looking at this MRI, where is the injury? Where is the injury that you are seeing, or where is the disc prolapse that you are seeing? So like you can notice, this is the level where the disc is bulging out. Normally you are seeing that the disc is limited here by the posterior longitudinal ligament, but here it is black, it is completely hypo-intense, suggestive of desiccation, that it has lost its water, and now it is prolapsing outside. Alright, so here always see where it's taking the curve. So this is S1. Alright, so the moment it takes a curve, that becomes your sacral 1 vertebra, the sacral promontory, and this is L5. So here the disc prolapse is most definitive at L5 S1 level. Alright, so this is again a repeat FMG question. They've asked you which level is the prolapse. So that is how you see where is it bulging out, and the best investigation to do so is going to be MRI. Alright, so on that note only, if I ask you, I want to see knee ligamentous injury, which is going to be the investigation of choice. So again, ligament comes into picture. What is it? It's going to be MRI, isn't it? It's going to be MRI. So going back and just trying to show you the image again. So this is where you are seeing the disc, alright? So even if I erase this, I'm able to clear it. Yeah, if you can see this, so this is the area where you are seeing the disc bulge. Yeah, Ambika? Alright, so going back. So knee ligament injury, right? So when we talk about knee ligament injury, again ligament, MR. And but if I ask you gold standard, anytime I use the term gold standard, I am trying to say something which is diagnostic as well as therapeutic. Yeah, so then you will say it is arthroscopy, isn't it? It's arthroscopy which serves as the ultimate investigation, which can see the injury as well, which can treat the injury as well. So arthroscopy will be your answer for gold standard. Alright, so I hope you guys are following the concept here. It's not about memorizing it all. You know the thumb rules, you translate it. So similarly, bone marrow edema, cortex was CT. But when I want to see the bone marrow, what is our main investigation here? It's again going to be MRI. A step further, if I ask you in MRI, which is the main sequence that will show me bone marrow edema, then you'll tell me, I have a lot of fat in the bone marrow, isn't it? So if fat, which is hyper intense, edema, which is hyper intense on T2, how do I know what is edema, what is fat? So do you agree we'll have to suppress the fat in order to pick up the white edema? Yes, so that is what we've done here. We've suppressed all the fat, made it all hypo-intense, such that any whiteness I see would be that of the edema per se. So if they ask you which sequence, particularly Central Institute exams, remember STIR. No need to remember the full form, but it stands for short tau inversion recovery. So STIR is a sequence wherein we suppress the fat. It's a T2 weighted sequence minus fat. So any edema will be white. Alright, so this is what it is. Yeah, Apurva, so exactly what I said, you have to try and understand what the examiner is trying to ask, So for the best investigation, usually will be the investigation of choice. Alright, but if they are already hinting to you, like tomorrow we'll study hepatobiliary, and a lot of times this question comes as far as MRCP versus ERCP goes, I'll tell you what to choose and when. Alright, but usually it will be investigation of choice when they say just best. Okay, right. So anytime we're looking at bone marrow edema, you go for MR. Particular pathologies wherein you want to look at bone marrow edema, stress fracture. So one exception of the fracture, do you remember from CT? It is stress fracture. Then osteomyelitis, again the earliest investigation. If they ask you a repeat question, most sensitive investigation for osteomyelitis, not X-ray, osteomyelitis, it is going to be MRI. Alright, so remember, most sensitive, best, earliest will be MR. AVN, avascular necrosis, again will start off with bone marrow edema. So earliest, best, most sensitive, everything will be seen on MR. Alright, so this is something which is important. Alright, so flare versus termid out here. So flare is fluid. Alright, so flare is also a T2 weighted sequence, but when I don't suppress fat, I suppress the CSF signal. Alright, I want to suppress the CSF signal, then it becomes a flare. So flare is usually done for brain. Alright, it's not done anywhere else because we don't want to suppress unnecessary fluid anywhere else, right? So it's usually used for brain only. Okay, wherein we want to see edema, brain edema. So again in neuro I will talk about it, but that's for brain usually. Alright, okay, so going ahead to the bone tumors. So now tell me, bone tumors initial, already discussed, thumb rules. X-ray. What about the best one? Best investigation for bone tumors. If they ask you that I want to see the extent of the tumor, I want to see if it's involving the neurovascular bundle, if there are any metastases within the bone, alright, which are called as skip metastases within the adjacent bones, what will be the best? It will be MRI, isn't it? It will be MRI. Except one tumor where we saw that CT was playing a very big role. That is osteoid osteoma, isn't it? So for osteoid osteoma, I want to see cortical thickening, and within the cortical thickening, I will see that there is a central lucent nidus, and that is what is producing the symptoms, the prostaglandins, and that is what we want to treat. So here it's going to be CT. Perfect. What is the gold standard for any bone tumor? How do you ultimately reach the diagnosis for any tumor per se, not just bone tumor? It's going to be a biopsy, isn't it? It's going to be a biopsy, and the pathologist will tell you what the pathology is, but you never go for biopsy upfront. You want to evaluate it radiologically first, always. Okay, so this is about bone tumors. Now let's talk about bone metastasis, something that a lot of you I know will make mistakes in. When we talk about bone metastasis, what is the best investigation? So remember, here the best investigation is PET scan, but what kind of PET scan? Can somebody tell me one newer PET which is the best for bone metastasis, not FDG PET like we do usually? Good, it is sodium fluoride PET. Alright, so sodium fluoride PET is the best. What if this is not in the option? What do I go for next? Can I go for my usual PET? Yeah, so next would be 18 FDG PET, which would be the second best answer. What if this is also not in the option? What else do you want to do? Something that can pick up bone marrow metastasis also. The moment I say bone marrow, what comes to mind? M for MR, isn't it? So the third best in this order would be MRI. And finally, something that we study in nuclear medicine. If I tell you I am doing a technetium 99 methylene diphosphonate scan, what am I talking about? What is MDP? MDP is bone scan, isn't it? This is our usual bone scan, and will bind. This compound will bind to anywhere you have new bone formation. So do you agree this will be much better for osteoblastic metastasis? Yeah, so that is what it is. Twinkle, in osteomyelitis, earliest change, if what I am trying to say is the earliest change, the most sensitive investigation will be MRI, right? X-ray will be an initial investigation that you'll do for the patient, but an X-ray will only start showing the changes after 7 days, after 14 days, alright? So it will take up to 1 to 2 weeks for X-ray to show the changes. That is why it's not the earliest one to show, to pick up. It's not the most sensitive. Yeah, I hope that point is clear. So this is about bone metastasis. Going ahead to the next one, when we talk about pediatric hip disorders or avascular necrosis of hip, initial investigation का answer will depend on the age. Less than 6 months का बच्चा is having DDH which is suspected. What will be the best investigation? The bone has not yet ossified. No point of doing X-ray. So here the answer would be ultrasound. But if the child is more than 6 months, so what are the 3 most common hip disorders? We have DDH, we have Perthes disease, we have SCIFI. slipped capital femoral epiphysis. DDH is the one which will present from birth to up to 5 years, right, commonly. Perthes is something which presents 5 to 8 years, whereas Skiffy will present in adolescence, yeah. So these are the three age groups that we have. So predominantly for DDH, we need ultrasound, remember that. But for everything else, AVN included, initial investigation, like everything in orthopedics, it's gonna be X-ray. But if I ask you the best investigation of choice, your answer now is gonna be MRI for all of them. Alright, for all of them, the best investigation, it's gonna be MR. Alright, so I hope this is making sense to all of you, very, very important. Then when we talk about osteoporosis, investigation of choice, it's gonna be DEXA scan. Alright, so DEXA scan, dual energy X-ray absorptiometry. This is the scan that will tell us about bone mineral density. But you got a question on what are all the investigations which are usually done to work up a patient of osteoporosis. First, we will do an X-ray to rule out any fracture, to see osteopenia. Next, will we do a chemical analysis of calcium phosphate PTH? Always, because we want to rule out secondary causes, isn't it? We want to rule out secondary causes like metabolic disorders, like vitamin D deficiency, hyperparathyroidism. So always these three are done. What else? Something recent. We have now come up with quantitative CT as well as ultrasound. So both of these are recent advances which can be used to see the bone mineral density. So remember, all of these have a role in the evaluation of osteoporosis. Alright, what doesn't have a role is bone scan. So remember, bone scan का कोई role नहीं है. It only binds to what? It only binds to newborn formation. There is no newborn formation which is going on in osteoporosis, right? So this was your exact DINI-CT question. So investigation of choice, DEXA scan. We use the WHO scoring here, which gives us an estimate of the density in terms of a T-score. Yeah, wherein the density is compared of our patient with that of a young adult. Okay, so this is what is done in DEXA scan. All right. Yeah, weight bearing exercise, not related to radiology. So this is something wherein the joint which is at problem will be given some weight and then you have some exercise. Alright, so as the name suggests, a physiotherapist would be a better person to direct this question to. But this is about MSK. Alright, so this was about MSK. I hope you realize that there are hundreds of questions which can be answered if you get these concepts correct. So very, very important that you see this class and revise this class before your exams. Next we move on to neuro. Alright, so thumb rules of neuro is what we want to see. Next, so when we talk about investigation of choice for head trauma, so what will your answer be? Anytime there's a patient with head trauma, the first investigation, the best investigation that you're going to do is what? I already said quantitative CT. It is something which is recent. It is not something which is very routinely done. Alright, it's a very recent advance, still not being done in practice, but it will come up and it is go on to become better than DEXA. Alright, so it gives a 3D evaluation of the bone mineral density, but it is not done routinely in practice as of now. So coming back to head trauma, yes, best investigation, non-contrast CT. Why non-contrast CT? Because something else that CT shows very well, apart from cortex and calcification, is acute hemorrhage. Remember this. Anytime you want to look at acute hemorrhage, acute blood collection, you want to do CT. So do we want to look at that in head trauma cases? Absolutely. So like you can see, acute hemorrhage, which is idly shape, biconvex. This is what is EDH. What is this? This is a subdural hemorrhage, banana shape, crescentic shape. So any acute hemorrhage will be white, will be hyperdense. Cortex, fracture. Does our thumb rule apply? Absolutely. So any fracture we want to see, we'll again go for NCCT. Except one case, again something that has been asked so many times. If I want to see diffuse axonal injury, which will present as multifocal petechial hemorrhages, very, very tiny hemorrhages. So can somebody tell me what is this sequence, which is something which will be showing me these black spots? Correct. This is susceptibility weighted imaging. The susceptibility weighted MRI, which is showing you these black spots wherever there's bleeding. So this becomes the best investigation for diffuse axonal injury, because there are very tiny bleeds which will occur here, which will not be picked up on NCCT. So they'll give you NCCT showing some petechial hemorrhages, or NCCT might even be normal, wherein this person will have a very low GCS score. So very bad prognosis, very bad neurological status, but CT underestimating the injury. This is the kind of overview that they'll give you, and you'll answer that I want to do an MRI to confirm by doing a susceptibility weighted imaging, because it looks like a case of diffuse axonal injury. Alright, going ahead to stroke. So stroke, remember the initial investigation that you will do is what? It is always a non-contrast CT. Again, the same thumb rule, because what do we want to do? Because we want to rule out hemorrhage, right? We want to rule out acute hemorrhagic stroke before managing these patients as ischemic stroke. Yeah, so this is what it is. Yes, so for calcium calcification also you will see this blooming. All right, so this kind of blooming can be seen with iron as well as calcium. Basically anything which distorts the magnetic field, any metallic element, we can use this. All right, so that is called as paramagnetic substances. So we want to see that, and that is why it appears as blooming. All right, most sensitive or best for picking up ischemia. If I tell you I want to know whether it's an ischemic infarct or not, what will your answer be? You will say it is diffusion weighted imaging. So diffusion weighted imaging is something which is the best to pick up ischemia. This is what it looks like. So it will look like an MRI image, but you will not see any bone, you will not see any scalp, isn't it? So any area of diffusion restriction, remember, on a diffusion weighted imaging will appear white. उसी को confirm करने, to confirm that we will also do a ADC image. Remember, it's not something which is a different sequence. It is something that the computer will generate for us, which is a counterpart of diffusion weighted imaging. So anything which is white on DWI should be black, hypo intense on ADC, and then I will say that yes, this is true diffusion restriction. This is definitely an area showing diffusion restriction in the scenario of stroke. This is definitely ischemia. Alright, so this is how we are going to do. And lastly, difficult question. If I ask you, I want to see penumbra. Well, how do I visualize penumbra? An area which is salvageable, an area if you reperfuse can still come back to life. It is not yet infarcted, it is not yet dead tissue. What will you say? You will say that you will have to do perfusion imaging. Alright, so CT perfusion, MR perfusion, both can be done. CT perfusion is usually preferred in practice. Okay. Yes, Ravleen. So diffusion weighted imaging is actually a variation of a T2 weighted image. Alright, so it's not a direct T2, but yes, it's derived from a T2 weighted sequence. Okay, so this is about stroke. Then when I tell you, can you tell me the best investigation for imaging of paranasal sinuses, skull base I want to see, or I want to see temporal bone. So all of these are tiny intricate areas, delicate areas, and I want to see what is going on. So do I need to do something high resolution? Yes, and all of these areas are bony areas, isn't it? They are composed of bone as well as air. So correct, we want to do a high resolution CT for all of these, right? So HRCT is going to be the best for all of these areas. Yeah, then let's talk about another important question, which is subarachnoid hemorrhage. So what is the initial investigation for SH? Subarachnoid hemorrhage, acute subarachnoid hemorrhage. Person comes to you with the worst headache of the life, throbbing headache. What do you want to do? Correct. Acute hemorrhage, NCCT. What is the best? Apart from trauma, what is the most common cause of SH? It is aneurysm, isn't it? It's aneurysmal rupture. So if there is no history of trauma, if there is spontaneous SH, how do I rule out aneurysm? Any vascular pathology, if I want to see, remember CT angio, emergency plus vascular translates to CT angio. MR angio will take time, so emergency CTA. What is the gold standard? Something that can diagnose this aneurysm as well as I can put in a coil and treat this aneurysm. It will be DSA, correct? So digital subtraction angiography, gold standard. Very, very important list here. Okay. Going ahead to AV malformation. What is AV malformation? Where artery and vein are communicating by a cluster of dysplastic vessels, which is called a nidus, which can sometimes rupture and lead to hemorrhage. What is the best to see this AVM? Again, is it a vascular pathology? Yes. Is it an emergency? Yes. So again, your answer is going to be CT, CT angiography. What is the gold standard for AVM? Again, something where I can diagnose also, and I can put in a coil here, I can put in glue here and block it. It is going to be digital subtraction angiography. Alright, so DSA is the gold standard for AVM again. So just because a lot of you guys get confused between the three angiography images, let's try and figure out what is what. So as simple as the bone visualizing. If you are seeing the bone is white, and this is the area of circle of Willis, you are seeing all of these vessels with contrast. What is this? This is CT angio. So yes, that does answer your question, that CT angio definitely uses contrast. Yeah, we cannot see vessels without injecting contrast in a CT angio. On the other hand, can I do away with contrast in an MR angio? Yes. So remember one more pointer here, that there's a sequence called time of flight. So TOF sequence is something wherein no need to inject contrast, you can still get an angiography image. So that is one big advantage of MR angio over CT angio, that in patients who have deranged renal function, you need not give contrast. Yeah, so remember that. So how would it appear? Everything else has been suppressed. You are seeing the vessels which are white. So this is the area of the circle of Willis. This is the ICA, which is giving rise to MCA here, going in the Sylvian fissure. This is the ACA here, going anteriorly and joined by ACOM artery. Posteriorly, you are seeing a small branch here, which is PCOM. And then this is the posterior circulation, the basilar artery dividing into ACA. Alright, so I hope this is clear to everybody. So this is what it is. Yes, CT angio preferred because it is much faster than MR in emergencies. And what is this? When you see that the background is subtracted, you are seeing just the vessel, you can perform interventions. This is DSA. Alright, so I hope these images help you. And finally, one last question on head and neck. A repeat question, investigation of choice to localize a parathyroid adenoma. It's a nuclear medicine scan which will bind to PTH adenoma. It is technetium 99M SESTA-MEB scan. So SESTA-MEB scan is going to bind and localize it to the best of its ability. Alright, so this is about that. CSF leak. When we are talking about a case of a suspected CSF leak because of trauma, what will you do first? If they ask you, how will you confirm that this is indeed CSF? This is not mucus which is coming out from the nose. How will you confirm? What is that biochemical test that you're going to do to confirm that is indeed CSF? So remember, if read between the lines, what are they trying to ask? Are they asking, I want to confirm CSF, or are they asking, I want to confirm the leak site? I want to localize where the leak is happening from. Yes. So when they ask you to confirm the CSF ही है, you will be doing beta 2 transferrin. But if I want to localize कि कहाँ से injury है and it is indeed CSF which is coming out, then you want to do HRCT, cysternography. So what is the meaning of cysternography? It means that now there is contrast. There is white contrast within the CSF cisterns, within the subarachnoid space. And if I see that contrast coming out through a site, through a defect, that is the exact site of localization, and that is the best to localize CSF leak. Alright, so this is HRCT, cysternography. Investigation of choice for calcification, anywhere. We know our thumb rule, very easy question. This is non-contrast CT. So if I see in a child with torch infection, periventricular calcification, CMV is what you want to rule out. Whereas the other differential, if you see parenchymal calcification, cerebral calcification, rule out toxoplasma. Yeah, whereas in the suprasellar area, if you see a calcified mass in a child, always think of C for craniopharyngioma. So cystic mass with calcification, child, it is craniopharyngioma. Alright. Finally, any tumors, investigation of choice for brain tumor, spine tumor, paranasal sinus tumor. Always tumors, MRI, Will you want to give contrast for tumors, for infections? Always. This contrast enhanced MRI that you wanna do. Alright, so CEMR investigation of choice for all of these tumors. What about demyelinating disorders? What about multiple sclerosis? One thing you know, yes, you want to do a flare sequence for sure, because what is flare? It's a T2 weighted sequence with CSF which is black. So what will happen to all the plaques, all the demyelinating plaques? They're going to start and appear white. Alright, so this is more sensitive to pick than just T2. So this is fluid attenuated inversion recovery, which is a T2 weighted sequence minus CSF. Alright, but if I ask you what is the best kind of MR you want to do you want to give contrast in multiple sclerosis? Yes, we want to. Alright, because this will help us distinguish active plaques versus inactive plaques. So this tells us about the dissemination in time. What is an active new lesion? What is an old lesion? So that gives us that there is dissemination in time which is happening. This is a part of the McDonald criteria of multiple sclerosis. Alright, so MS, demyelinating plaques in the periventricular region, Dawson fingers. Remember, CEMR is the best investigation. Right? So I will stop here. I've overshot my time by 6 minutes. So I hope this was useful. If I was in your place, this would have been very, very useful. This is very high yield. Alright, so just keep this, save this PDF, and do watch this video before your examination. You will get most of the questions right from radiology if you can just see this series alone. Alright, so I will see you all tomorrow 4 o'clock for this. Okay, so I'll see you all tomorrow 4 o'clock, and we continue with CVS, GI, GU, hepatobiliary and respi. Alright, so we'll try and do as much as possible. So this is what we're gonna do, and apart from that, I'll see you all again today at 9 p.m. for FMG students. Alright, so this is an FMG. I'll tell you the strategy to prepare, as well as we'll be looking at previous year questions. So any of you who are interested, the NEET 2022 aspirants also should attend this. We'll be doing. So this is on the app. So this is on Unacademy at 9 o'clock. Apart from that, at 11:30, just before you sleep, we'll have a short 15-minute session, and we'll look at some radiological anatomy. So every day on YouTube, we'll be meeting now for the next 11 days at 4 p.m. and 11:30 p.m. So both short sessions, so this will be 30 minutes, will be 15 minutes, just some images, quick review, so that we have our radiology revision in place. Alright, so thank you so much guys, and yeah, eventually we'll put them all in a single playlist. Yeah, but you can, jo abhi tak hue hai Jay, you can definitely find it on the Unacademy channel under my name, whatever sessions I've done till now. Okay, alright guys, so thank you so much. I hope this was useful, and see you all.